Hello and welcome back to the PSC in Conversation. I'm Jonathan Chappell, a senior partner here at the PSC. So for years now, we've been helping clients in the NHS navigate the complexity of the shift from analogue to digital ways of working. But with the headlines continuing to focus on the need for ever improved access for patients, whilst also helping clinicians with the reality of incredibly heavy workloads, the reality of making change has been never more relevant to talk about. So today I'm with some PSC colleagues and we're going to talk about the 10-year plan and the elements around analogue to digital shift. We're going to talk about three things. We're going to talk about administrative processes, AI in clinical care, and then empowering patients through digital access. And it should be a fun conversation. So I think first off, and thank you all for joining, Jack, I think I'm going to hand over to you to talk about the unsung hero of digital shift, which is anything you can do around helping process for all staff involved in care. So what are your reflections on that one?
Thanks, Jonathan. And great to be here. So I have come at this from all sorts of angles in my life, both as a consultant here at the PSC, helping clients work through some of these challenges. I've also been, quite often to my dismay, experienced some of these problems working as a doctor in hospitals myself. So I guess I can really see, I've seen firsthand how important it is, but also how impactful it can be when it's done right. I think a really interesting example of where this is challenging and perhaps more challenging than it first might seem, but also just incredibly impactful, is some of the work we've done helping a large ICB rollout piece of software called Optica, which is part of the federated data platform. That is a cloud-based piece of software that's designed essentially to provide a single source of truth for the patient's discharge journey, essentially, from when they're first referred in from support staff through to their kind of disposition either to home or to a local authority. Now, this was a fascinating project because it was so complicated. So the ask was quite simple, which was, this is a great piece of software. It's much better than sending spreadsheets, which amazingly was still happening multiple times a day. It's much less painful than emails and phone calls. It's GDPR compliant at the very least. Using this as a no-brainer. A year later, I would say that most people are using it. And that's because getting those processes right is so challenging. So the IG took a long time to line up. Some of the technical side of things took a long time to line up, but really it was getting the clinician buy-in, getting the discharge hub and kind of operational buy-in, and getting the local authority system leader buy-in that took all of the time and all of the challenge. These processes are so complicated. You know, a discharge pathway can look like the wiring diagram for a space shuttle, if you kind of map it out onto a PowerPoint slide, which is why it's so critical that this is done right, but also why people can be quite skittish and quite nervous about messing around with how those things are done, because the stakes are so high. We've had enormous success with this in the past. I think when we supported Hull with their discharge transformation journey last year, we had some fairly staggering statistics. I think the implementation of Optica as part of this wider transformation pathway transformation, freed up an entire grade 9 social worker. They managed to cut out 2 MDT meetings every single day. I think there was some kind of staggering statistic, like a 98% reduction in phone calls or something like that. So the reduction in overhead burden here is absolutely massive. But I think the message here is that it's not just as simple as saying, here's a piece of software, turn it on, because teams are working under such significant operational pressure. And the risks of getting things wrong are so great. And bluntly, the capacity to learn new processes, redesign bits of governance is just really not there, particularly, for example, in the winter or in the run-up to winter.
Really interesting example, and I think testament to the work that the teams in Hull, and I'm sure others who've rolled it out will have done in making that work. And so I was reflecting, Jack, as you're saying, there's something here about using the data platforms to provide an authoritative single view of the truth, and that being something that can really reduce any actually sort of ineffective communication of messages. You avoid the sort of the missed factors. but also it gives you something that can mean that the communication becomes pretty seamless. So people can find out what they need to as and when they need it, rather than having to rely on waiting for an MDT, for example. So you can see the sort of power of that. I was interested in one of the things you said about, so clearly you work as a doctor sometimes too, and I'm sure you've seen this from that side. What as a clinician makes these sorts of bits of software most helpful to you? Like what's the thing we want everyone to hear about making the biggest difference to your life as a clinician?
So that's a really interesting reflection, Jonathan. Thank you. And I think I sort of alluded to it earlier when I used the phrase "a single source of truth." Now that's said so frequently in so many contexts that it can be devalued sometimes. But I think that's the critical goal to try and get to. I think whether you're a clinician or a social worker or someone working in discharge operations, the real challenge when you have so many people involved in someone's care at so many different times is knowing what is the actual state of play for this person at this moment today. And that means that you're not just searching through notes that were, is this note written yesterday still valid? Do I need to call them and check? Is there a note hidden in another bit of this software that I haven't seen that's actually overridden this, for example? Or is there a referral template somewhere else in this piece of software that's been filled in incorrectly that I can't see? And that's where the real value is, and that's where the real time saving is for things like Optica. When it's done right, it can be so powerful, because you know that you click on that patient, someone's added themselves, someone's ticked the box, and that's all you have to rely on.
Thanks. That's really interesting to hear. So it's both efficiency, but also the experience of doing the job, as it can take away some of that cognitive burden that you can then use to do other things like caring for patients. So a really powerful example. I wonder whether at this point, Joe, I might bring you in, because I think we've talked there about some of the sort of operational administrative processes around making sure care gets delivered in the right place at the right time. But actually, one of the other big themes in the 10-year plan is around using technology, and particularly AI, to support clinicians in the workflow. What are your thoughts on that area?
Yeah, I wanted to talk a little bit about things that are happening out there, and then think about what they mean for NHS organisations, what they might mean for some of the work that we do. And AI is nearly all anyone talks about anywhere at the moment, so you're going to have to forgive me to add to that over a few minutes. But there are clearly deployments of AI across care pathways at the moment, in radiology, wider diagnosis and decision support. Lots of talk about the potential for AI as part of the genomics strategy, AI-assisted treatment, and then to a lesser extent, but more and more, AI-assisted follow-up and remote monitoring pathways as well. So I thought I'd just talk about a couple of examples which have in common that they are about harnessing sort of AI's well-known ability to make sense and find signal in masses of data to a much greater extent than we could just a few years ago. So the first one you may have heard about is Pharos AI, which is built at KCL, creating an AI-ready integrated data set for cancer. So we know that cancer care generates loads of data of different types, imaging, pathology, genomics, and patient records. And what Pharos are doing, bringing that data together into a federated platform that links those different modes of data, multimodal data, at the patient level, and creates like a 360-degree profile of the patient. And the idea is there to create like the data foundation that enables AI working at like industrial scale to start to make links between individual data sets, and enables researchers and innovators to develop and demonstrate new treatments and diagnostics. And also has application at sort of strategic commissioning scale as well, in terms of better understanding population health and aligning care to the needs of the local population. And then the other interesting one is in relation to still cancer, but we're now talking about lung cancer. So as of quite recently, January this year, NHS announced an AI pilot which is pairing AI imaging, which we've heard lots about, with robotic bronchoscopy, essentially an instrument that can navigate deep and dark parts of the lung. That the AI part of the pathway is about using machine learning to flag very small nodules on CTs, which are then reviewed by a human clinician for diagnosis, and then the treatment is the robotic bronchoscopy, which is better at finding accessing those very small nodules in a way that's sort of minimally invasive and supports patient experience and outcomes. And so the interesting thing about that one for me is that it's like lining up complementary technology. So we're now better with AI at locating these very small nodules than we've ever been before. But the only way that adds value to the whole pathway is if we're also very good at accessing and biopsying those very small nodules through minimally invasive techniques like bronchoscopy. And then those two technologies need to have an access point in the pathway that enables them to be deployed in the right place and actually improve outcomes. So NHS have the goal of diagnosing up to 50,000 additional cancers by 2035, at least 23,000 of those at an earlier stage than previously. But the entry point in the pathway needs to make sure that those earlier diagnoses translate into better outcomes for patients. I think that's really the really interesting thing about deployment of all technology in care pathways, but particularly true of AI, is like where can we find the entry point for new technologies and scale up to drive real impact.
Thank you. Really fascinating examples. And I guess, as ever, it's often the combinations of technologies where you see the real advances at pace. And there's also a theme there about in any work we do with clients, whether it's in healthcare, as we're talking about today, or in other parts of public services, the secret here is about providing a service that makes use of the technology rather than digitizing the pre-existing service. So the example you're giving there about actually those technologies allow a completely different imagining of how one runs a patient pathway for example, a lung cancer, rather than sort of looking at what used to happen and where this might provide a little change to it, I think is a really interesting and perhaps the bit that makes it complex. I wondered actually if we just keep with that theme and actually, Hailey, bring you in at this point, because I think sort of combinations here of sort of AI combined with other things and thinking about patient empowerment. What are your reflections on that area?
Yeah, so I wanted to talk about my experience with patient empowerment in terms of, as a nurse, kind of seeing patients interact with these digital tools and the changes that it has on the way they receive care. And then some of the work we've done at the PSC in terms of engagement and lived experience with digital tools. So the first area I wanted to talk about was the universal care plan and giving patients a documented voice digitally. And I think it kind of aligns with what Jack was saying in terms of having one location where they have all of their information in one place. And I've seen in community settings, this can be a big challenge for patients as they have many people coming into their homes, doctors, nurses, therapists, and they're having to repeat their stories many times. And their voice often gets lost between teams, especially in urgent care settings. If they're making a decision to go into hospital or they need to call someone and the care team doesn't know who they need to call. So digital tools like the Universal Care Plan can be really empowering because it's a central place for them to have all of their preferences, their needs, what matters most to them. But then it can also be a more holistic tool where they can include their wishes and details about their mobility or domestic care that they might need at home. So it's kind of bringing that more holistic view to healthcare, but then also giving them the information that they might not have had previously. So the Universal Care Plan is accessible in the NHS app. So it's something they could have right on their phone. But then it's also accessible for clinicians as well. So ambulance teams, physios, nurses, doctors can all see it in one place and have that pulled across. And it pulls from different EMRs as well, which is really exciting. So it reduces the amount of time for clinicians as well. So yeah, that's one tool that I find really exciting. But then there's also virtual wards, which is an area that I've worked in as a nurse. And this is the delivery of acute hospital level care at home. And I find it's empowering in itself because it allows patients to be in control of when they sleep, when they eat, kind of their day-to-day activity while they're still receiving that hospital level care. They can have their family members around them. And it's digital tools that are allowing this to happen. So remote monitoring is the biggest one in virtual wards. And there's been a lot of advances in the level of observations that we can record at home and the frequency that you can do that. So it's really exciting what it's providing for patients, but there are challenges as well. So I've seen the challenges that families have with using the remote monitoring technology, and doctors and nurses are becoming the ones to kind of onboard and upskill and teach family members on how to use those tools. And it is a change of workflow for clinicians and for patients and families. So I think it's important to make sure that the technology is designed with patients and families in mind, because they'll be the ones using it. And the language that we use and how we talk about observations and monitoring is friendly and is kind of thought about in a way that will be easy for them to use. So yeah, I think virtual wards are also really exciting, but lived experience is the most important when designing these and making them as empowering as possible. And that's some of the work we've been doing at the PSC, is running engagement sessions for different clients to get feedback on digital tools and learn about how patients and families can use them, different challenges they're facing, but then also where they see the opportunities and what will be the most beneficial. So yeah, I think overall it's really exciting.
Thank you. That's really interesting. And that perspective you're bringing there about how the patient empowerment gives so much benefit to patients, families, carers, and also makes it a different relationship with the clinical team supporting them, and that's a benefit there. But also, when we talk a lot about the sort of workforce and education challenges, but actually there's something here that's like not only helping everyone understand what's available, but also, as you're describing, Hailey, that change in role is actually almost like a digital coach that the clinician then has to also be on top of that sort of the rest of the job, and how actually that's made as easy as possible for people, both through good digital design, but I suppose also through how we think about the next 20 years of what a career in care might look and feel like for people. I think that's a really interesting area to explore.
Yeah, I think thinking about those things from the outset is really beneficial when designing the tools. It makes it easier for clinicians to coach and teach when they put them in practice.
That makes sense. Give them the best possible tool with the easiest, so the most seamless and I suppose human language, and then actually, hey presto, that gets a lot easier.
Exactly.
Nice. I wonder whether actually sort of question might come back to the wider group. As I had for all of you, thinking about the different areas you're emphasizing, is we're thinking a lot about the next 20 years at PSC at the moment. And what for you today, I appreciate we're having this conversation right now, is the most exciting thing for you about the potential of the analog to digital shift over the next 20 years? We've touched so far on such a range of areas, from the potential of data at scale, multimodal data. We've talked about the ability to make processes and pathways seamless and to have one view of the truth. And we've also talked about the impact for patients and like fundamentally really transforming that relationship that an individual has with the broader care system, health and care more widely. So there's quite a range of things. So I was just interested in like what's sparking your excitement most. I wonder whether, Joe, I can see you've leant forward. What were your views on that?
Yeah, we're here today to talk about the shift from analog to digital, which is clearly one of the three shifts at the centerpiece of the 10-year plan. And I think the thing that's most exciting to me is actually how we can harmonize that objective with the other two, which are, of course, the shift to prevention and the shift to community. And there's clearly like an important equity angle here, because I think there's a world in which AI enhanced care is accessible to a few who can and potentially pay for it, and isn't geared towards actually redressing still major challenges with health equity, and also major challenges for improving preventative and proactive care closer to where people live. So I think the thing I'm most excited about over the next 10 years of the 10-year plan, of course, but the 10 years thereafter, is thinking about entry points for new digital and data technologies that are preventative and are about, harnessing the predictive power of technologies like AI to get in earlier in pathways and improve outcomes for everyone.
Thank you. That's really powerful. And I think one of the things that often is important to talk about, as you've brought up, is the need to deploy these in a way that reduces health inequalities rather than accidentally exacerbates them, and to think about access for all patients and carers and families. So I think that's really interesting, how we can get ahead of the curve and use these insights to really reimagine what's possible. Nice. Jack, what's your reflection on excitement?
Look, I think there's a huge amount to be excited about here. In my head, obviously, coming at it both through my own experience, then we've done a lot of stuff together, Jonathan, you and I, on harnessing health data properly and at scale. And we were, even a few years ago, much earlier on that journey than we are now. And we've talked, even what you were saying, Joe, about, harnessing, whether it's cancer data or other data, really genuinely getting to grips with it at scale, and then drawing the kind of inferences that would be impossible 5 to 10 years ago. That's fascinating. I think perhaps more modestly, but no less helpfully and excitingly, and definitely from a patient perspective, very usefully, is we're at the early stages now of being able to draw health and care data for an individual patient together properly and actually properly integrated. So, now we have in most places a shared care record where you can have kind of read-only access to different systems. That's not enough for you to get the whole story, and you can't draw enough of that data out in a way that will allow you to actually use things like predictive AI to make inferences and predictions about that patient's health, prognosis, risk of developing a condition, their prognosis. That potential is amazing. Actually pulling together primary care data, secondary care data, even integrating it with demographic data, education data, where they live and their index of multiple deprivation decile in their postcode. Once we can get there, and we're really not far off, the potential is enormous, because now with things like AI, we actually have the compute to answer some of those questions.
I think that point on compute is really interesting. I know we've done bits of research as a firm on looking at what quantum computing might bring, and how that actually some of the use cases that really just require really significant computational power might start to become available. So if we have that understanding, it's centered around what the public want and what patients then really are experiencing, then that feels like the right way to be able to harness that opportunity. Hailey, how about you? What's most exciting from your perspective?
Yeah, I think in keeping with the patient empowerment lens, and also thinking about integration and care records and predictive analysis, I think personalized care is what's most exciting to me, kind of thinking about how we, using these tools, allow patients' voice to come through even more, and how we can kind of make care unique to the patient, and make sure that their preferences and decisions that are made are based on their own information rather than kind of a more generalized pathway or what we've done historically. So yeah, I think that's what's most exciting.
And as I asked the question of all of you, I guess I should probably answer it myself as well. I think, thinking together a lot of what you said, actually, it feels to me like we're at a place where, as life expectancy has gone up, but actually healthy years lived hasn't necessarily kept pace, particularly if we think about for all communities and individuals. And one of the things that strikes me about the analog to digital shift is it's opening up change and transformation in some of those things that are drivers of ill health, but not necessarily sort of high-end healthcare usage. So if we're thinking about musculoskeletal conditions and allowing people to live in a different way and have a different treatment regimen, or we're thinking about depression or some of the more common mental health conditions, actually quite a lot of what we're doing here is bringing together information that allows people's preferences and also goals to be understood in a different way that actually can really make a difference to people's lives in the most meaningful way. And I think that part of it is really exciting. And then on the other side, I'm also really excited and actually have the privilege of doing quite a lot of work at the moment on actually completely new insights around sort of the precision part of precision care and precision medicine, where actually if we do understand the genomic basis, then actually you can get into a slightly different conversation about what's the right treatment and really get ahead of, with some advanced therapies, curing conditions that otherwise were with people for their whole lives. And if you add those things together, it feels like in 20 years, there's quite a lot of optimism for different people, and actually any challenge people might be facing. So that feels like real huge opportunity for optimism. I wonder whether I might ask an additional question as we're all here together, which is thinking about, you've all talked eloquently about what's possible and how some of the challenges in using digital technologies kind of come up. So what bit of advice would you give to someone you were talking to who is trying to accelerate the use of digital technologies to make care better? What's the kind of big thing, or maybe the thing that comes top of mind on, like, what's the thing you should really focus on? I suppose we've talked a lot here about grounding. That for me personally, I'm thinking here about make sure you're grounded in what patients, carers, families, and the public are telling you is most important to them. And we touched in different ways on how that's possible and how there's lots of research out there on that, and also how you can engage directly on the specific issue. What other thoughts or advice might any of you have? Jack, do you want to come in on this one?
Sure. So for me, and I know I've alluded to it earlier, but I think for me, the critical thing is building a consensus and, really getting that case for change across to the people who are going to be using it. I think there is, as a result of some structural inevitabilities in the way that these technologies come to be delivered, a lot of top-down sort of implementation styles with these kind of technologies, in that they're quite often expensive and they need to be delivered system-wide and at scale to be effective. The challenge you have, and I'm sure we've all seen in practice, is that you need to really basically make the case to the user on the ground, not just why it's important and why they should use it, but how they're going to use it in a way that makes them more able to do their job and not less able to do their job. Because there is a very closely overlapping Venn diagram of priorities most of the time, but they're not exactly the same. And it's easy to fall down if you don't bear that in mind when you're trying to implement stuff like this.
Thank you. That's really helpful. So given the complexities, don't forget we're all on the same team, but don't jump over that part of making clear on why this is going to help and what we really need to focus on.
Exactly.
Hailey, how about you?
Yeah, I think the importance of just thinking about patients and families again is making sure that you understand what other tools are out there and kind of what people are already using and how you might be able to integrate those from the start. There's a lot of new digital tools and digital processes coming, and there is a bit of fatigue, I think, in terms of learning how to use them and getting upskilled. And even when you have a new app or just say the NHS app, for example, that can change, and patients and families are having to keep up with the pace of change of these tools. So just making sure that you know what else is out there, how people are using it, and how to make it as easy as possible is more likely to lead to uptake.
Great, thank you. And I think I'm hearing implicit in that is that there is a lot that's already out there. So actually quite a lot of the art here is using what's already available in a way that meets the challenges people have day to day. And actually there's a real opportunity in that. Thank you. That's really helpful. Joe, how about you?
Just thinking about, and sorry to be a bit of a realist, but in a world, in an NHS where we're told, the money is the money, and the government has competing priorities for public money, building the business case and being able to think and demonstrate how the shift to digital, from analog to digital rather, generates financial benefits, where those benefits flow in the system, and having ways of aligning decision makers on essentially the business case and a clear sense of when those benefits will be felt. So there are a number of things that we've talked about where the cost is incurred now, but some of the benefits might not be or won't be in this financial year, may not even be in this financial decade. And so having the evidence base that enables innovators and clinicians and all sorts of people to make that case, that's going to be really important.
Thank you. That's really, really important. And being a realist, always welcome, particularly in making real change that matters for patients and families. So just want to say thank you all for taking the time to have this conversation today. I think I've really valued the opportunity to talk about both what's possible and how much impact that can have, but also some of the steps required in building that coalition, being clear on where you're trying to get to it with it, and also using what's already available in the most effective way so that it doesn't provide too much of an overload for people. I think if we keep doing that together, lots will be possible. So thank you, Hailey, Joe and Jack, and look forward to seeing you all soon.